I'm a neonatologist at Sultanah Bahia Alostar, Kedah. Today I'll be talking about the amplitude integrated EEG, or AEEG, or some of us refer it to as a CFM, which is the cerebral function monitoring. Basically, I think a lot of people are quite scared to use this AEEG, and a lot of people, once they've gotten the AEEG, has a lot of difficulties using it. So hopefully today's session will slightly enlighten you all and give you all the courage to use it as a tool in your NICU. So first, I'll just go through what AEEG is all about, and then how to set it up, and then hopefully we can go through how to interpret the AEEG and how do we use it in the NICU. Then I will have some tracings from which I've downloaded from the internet, and also some of mine, and we can ask some participants to give the answers. Okay, so basically the amplitude EEG is started by the adult population by Pryor and Maynard in the 1960s as an intraoperative monitoring of cerebral function during surgical anesthesia. And then only in 1980s, it is adapted for our use in the NICU, especially in the asphyxiated neonates. And also nowadays, we mainly use the AEEG in our babies with neonatal encephalopathy as well. So what is good about it is it allows for continuous cerebral function monitoring, and it is easy to set up, and also it's supposed to be easier to interpret. So what is amplitude EEG? So as we know, what an ECG or electrocardiograph is, the recordings actually measures the differences between the electrical potentials between the electrodes, and it displays changes in electrical activity over time. So I guess most of us are more comfortable looking at ECG tracing, but when we look at the EEG tracing, sometimes we do not know what it is, other than the neurologist. So in conventional EEG, in the neonate, up to 16 electrodes can be arranged on the scalp, according to the International 1020 system. So let me see if I can get a highlight, a laser pointer. Okay. So the scalp is, if you look from the vertex, this is the nose and the ear. And so the even numbers are on the left, and then the odd numbers are on the left, and then the even numbers are on the right. So we will basically it is divided to these areas, and for us using the AEEG, generally we use the F3P3 and F4P4. But some would use the C3P3 and also C4P4 if we are using double channel. If we are using single channel, then it's mostly the P3 and P4. I'll go into that a little bit later. So this is according to the International 1020 system. So some of you might be wondering what the 1020 system is. Basically, all these spots on the scalp corresponds to a very specific area on the scalp. So how the the technologists will put the electrodes is they will measure from the ear to the other ear, okay, and then that is 100%. So they will go 10% of that, 20%, 20%, and then 20 and 20 and 10, and it goes the same for the from anterior to posterior as well, 10, 20, 20, 20, and 10. So that's why the name is 10, 20 lah. Okay. So then you might be wondering, why don't we just use the conventional EEG with all the traces and everything for our monitoring? So basically, as I said, it is quite complicated. Number one, to put it on. Number two, the interpretation is also complicated. And then a lot of times, the brain-generated EEG signal is of low amplitude, and it can be easily contaminated by biologic artifacts. For example, if like the muscles on the forehead or the movement of the eyelids, everything can cause artifacts. And non-biologic artifacts, for example, the ECG can be an artifact, and also, for example, the waveforms from the high frequency ventilation can also cause artifact as well. And then because the EEG, if you look at it, similar to the ECG, it is a tracing for that time at that particular spot. So it's difficult to see trends because unless it's like a AEG where everything is more compressed over a few hours rather than a tracing which is just for a few minutes, then it's a little bit difficult to look at trends in that sense. So that is why the AEG, since it's more compressed, then you can see trends more easily. Okay, so the next one is to I'm sure you all must have had experience putting on the EEG electrodes, and to keep it there for a few hours is already a challenge. Imagine putting 16 electrodes at least on the scalp and maintaining for 72 hours, especially when we are doing it on our babies with neonatal encephalopathy. That is very, very difficult to maintain. So because of all these reasons, the amplitude EEG is supposed to make it easier for us who are non-neurophysiologists or trained technologists to do and also to interpret. Just to explain some nomenclature on how to set it up. So basically, you can divide AEG machines into single channel or double channel. So single channel, like I mentioned, it will be at the P3 and P4. And this is the ground or reference electrode. Okay. And then, but from here, you can only see a single waveform on the tracing. Whereas if it's a double channel, which we use F3, P3, F4, P4, then it will be double channel, means that it can actually differentiate whether the waveforms are from the left side or from the right side. Okay, so most of our newer AEG machines are supposed to have a double channel, at least. Okay, so why do we choose these areas? Because the underlying cerebral cortex below these areas is at the boundary zone of blood profusion from anterior, middle, and posterior cerebral arteries. So what we call as the watershed areas, if we remember from our reading when we were medical officers or even younger than that. And these places are sensitive to ischemia caused by systemic fall in blood pressure. So that is the most common area for abnormality to happen. And so that's why we put the electrodes there in order to be able to pick up abnormalities from the most common area for abnormalities to happen. And it is also free from artifacts from scalp muscle activity from the temporal region, and also eye movement from the frontal area. So it's actually quite far away from those that can call what we call biological artifacts. Okay, so how do we get the AEEG tracing? So this is a little bit technical. So basically, the EEG tracings will go through first the amplifier, and then there will be an impedance signal injection. So I will talk about what impedance is later. Then the waveforms are amplified and then filtered. Okay, filtered means that whatever that is below 2 Hertz and whatever that is 15 Hertz are actually taken out. Okay, and then from there, they will be compressed with a semi-logarithmic scale, which means that for the first, I think it's 10 or 20, it's going to be more how to say, more standard, and then thereafter it will go on a different scale. Okay, I'll show you in a while. Okay, then after that it goes into smoothing, and then it comes out as the waveform that we are familiar with. So from the raw EEG, okay, so as they go through the asymmetric filter, So you can see the filter, those that are very low and very high are actually filtered out. Then it will go into a semi-logarithmic scale. So you can see here, initially it'll be like 1, 2, 3, 4, 5 until 10. It's quite, the scale is quite big. And then thereafter it's more compressed to 15, 20, 25. Okay, so that's why it's called semi-logarithmic scale. Then after that it's rectified, and then it's smoothened, and then it is compressed in time. Okay, and then from there only we will get our the AEG waveform that we are familiar with. So this compression in time is important because when I first got my new AEG machine, we were wondering why the waveforms looks quite abnormal, and then we are missing out a lot of the background activity. So when we look at it carefully, then only we realize that actually the speed of the EEG tracing is not right. So that's why it is not compressed in time, and that's why we are not seeing the waveforms that we are more familiar with. So you need to be careful with the machine that you are using. Okay, so from the raw EEG that is here, okay, so you can see at this area, the amplitude is bigger. So that corresponds with the higher spike up here. And this one is a smaller amplitude, which corresponds to the lower end of the bar, so-called bar here. Okay, and then that's the scale I mentioned, the 5, 10. You can see that the spacing is bigger. And then once above that, it goes into 25, 50, and 100, a different scale. So it's semi-logarithmic. So when we set up our AEG, we need to be familiar with what we are using. So the electrodes, there are 3 different types, which is number 1 is the gold cups, number 2 is the hydrogels, and number 3 is the needles. So I'm not sure, so you have to be familiar with what which electrodes that are using. So I've used all 3 of these before, and I find that the needles are actually the easiest to use and maintain to achieve a very good impedance. So the hydrogels are very tricky to use, and the gold cups are also tricky to apply and to get a good impedance. Okay, but with our new machine, we have mostly switched to the gold cups, and I find that my MOs are getting much better at placing the cups. So I think a lot of people find it challenging to put the cups on. So I'm just going to explain a little bit how we do it. First of all, we need to, when the baby comes out, generally we use it on the baby with neonatal encephalopathy who was just born. So we would like to wash and basically we just use sterile water to wash away the liquor and blood that is on the scalp. Careful not to use saline because saline can interfere with your gold cups, and we don't shampoo the hair. I don't think we have the time to do that. Okay, so next is to place the electrodes. So we don't put the ground electrodes on the shoulder like this. We actually put it on the scalp itself. So I have this is a kind of a ruler that is supposed to make it easier to place the marking for the electrodes. So I've bought a few of these, and I'm in the process of distributing it to our Kedah hospitals. So basically what it does is that this ruler, I don't have a better picture. So this ruler has 2 parts to it. One is here and the other end is up here. So and this has like a B, C, D, E, F, A, B, C, D, E, F. So what we are supposed to do is we'll slide the ruler. One end we'll place at the triggers, and this side of the ruler should be parallel to the plane of the face, okay, and the other end should end up at the vertex. So the alphabet here must correspond to the alphabet here. Okay, so let's say if this is C, which is at the triggers, then it should be C at the sagittal suture as well. Okay, so once you line that up, then you will have the arrow that is up and down like this. So we can mark this up here and mark another one down here. But I've confirmed that this actually will correspond to the C3 and P3 positions. So I presume that if you were to put, you can mark the P3 here, and then we can move the ruler another to the other side, so that this place will be at, in line with the triggers in order to get our F3 if we are using the F3, P3, F4, P4 markings. Okay, so once we have marked that up, number one is we need to after washing lah. So so this is considered number two. So number two is actually we need to get to the skin. So we generally don't shave the scalp anymore lah. When we are using the gold cups, we use a little bit of the new prep, and then we will part the hair to get to the scalp, and then we use the new prep in order to scrub that area. Okay, so this is the new prep. So once we have already scrubbed that area, we will use a gauze to clean off whatever new prep that is there. Okay, then we will take our the gold cups, and then we will put our gold the 1020 paste into the gold cups and to put at the markings that we have put on. So a few things to note: the 1020 paste must not be touching each other because they can cause interference. Okay, or if you are using the hydrogel electrodes, then it shouldn't be touching each other as well. Okay. Secondly, you would want the wires all to be facing upwards so that you can group those wires together and try not to have anything touching, how to say, like to compress on the wires or touching the wires, because especially if that thing is like, for example, like the ventilator tubing, if it's like crossing those wires, it can actually cause a lot of artifacts. So we try not to do that and try to group those wires together and to place it far from the other things that can cause artifact. Okay, so in our machine, we are using the Natus Electro Works. So we will have actually 6 electrodes. So 1, 2, 3, 4. One is at the vertex is ground, and then at the forehead is a reference. So for us, we will have 6 electrodes. So once all these are set up, then we will check how the impedance is. And then we aim for impedance of less than 10 kilo ohms. And then only we will start the recording or the reading. Okay. So this is the Olympic Brains monitor. I think Langkawi has this machine. It's a very nice, and I think it's very easy to use compared to what we have, because ours is actually meant to do a full montage EEG. So whereas this Olympic Brains is specifically for AEEG. So what we want to see actually is, number one, there is a tracing for the impedance, which we don't have in our machine. So we will need to just on and off check the impedance for our machine. Secondly, it should show the AEEG. If it's a double channel, I have the left side and also the right side. Okay, and then you have the raw EEG down here. So the raw EEG, this part actually just corresponds to a small fraction of the highlighted area in the middle. So generally the AEEG will have a bar like this, and then you can select it there and then to click it in order to get your raw EEG. Okay, so that is how we set up our AEEG in regards to the how to place the electrodes lah. So I'm not sure what machines you all are using. I've heard that certain centers have got different AEEG monitors. Kulim is getting has got which one again? Philips, is it, or something like that? Minray.
We have Minray here in Kulim.
Minray lah. I didn't get to see your machine the other day lah, so I wish I could have seen it. Anyone has any other machines? We have the Natus Natus NeuroWorks, and I've mentioned. I think HDF also has Kangga also has the NeuroWorks lah, and Langkawi has the Olympic Brains. Not sure what other brands are available that are being used in the other hospitals. Okay. So any questions about how to place the electrodes? No? Okay. So it's a little bit difficult for me. Sometimes I feel I'm talking to myself because I don't see anyone here. So if there's any question, you can stop me anytime, okay? So next we will go on to the interpretation of the AEEG. If you get the concept, then generally you will know what to look for in your own devices. So when we are interpreting an AEEG, there are a few steps that we need to take before we can sort of interpret the amplitude EEG in correlation with the raw EEG and also the clinical findings. First of all, there are just 4 steps to it, basically. Number 1, we must make sure that the impedance or the contact between the electrode and the scalp is good. Okay, if it's not good, then whatever tracing that you have is practically useless because it's not interpretable. Secondly, we will analyze how the background activity is. Thirdly, we will look for seizure activity. And last but not least, to look at artifacts. So simple, right? So only 4 steps to it. Okay, so what is impedance? I've mentioned this a few times already. Okay, so basically it reflects the quality of contact between the skin and electrodes. So like how our ECG is, if your electrode is not stuck to the skin properly, then whatever waveform that is out there is cannot be interpreted, and it can cause false readings as well. So if the number is high, means that the impedance number is high. That means the contact is not very good. So it increases the artifacts and artificially increase the voltage of the background activity. This means that if the high is not good, so we aim for less than 10, but sometimes it's really, really difficult to get less than 10. So if I get like 10, between 10 to 20, also I'm very happy already. Okay, so I think it's still interpretable if it's within that range. But if you cannot even see where the limit is, then probably that's not good at all. Okay, so like I mentioned just now, some machines will have the impedance displayed together with the AEEG, and I think this setup is the most convenient. So we can easily see that, okay, this reading, there's abnormality here. Okay, the impedance is good, so I can actually take that into account. But for my machine, I need to go and open up another window with the impedance is, and once I close that window, I cannot see that whether the impedance is good or not already. So a little bit troublesome. So sorry, this is a little bit blur. So basically, here, this is the AEEG waveform. This is the raw EEG, and then the impedance is good now. Okay, so it's below 10. Okay, but if you compare with here, you can see that the AEEG suddenly has a shift in the baseline to the top here. Okay, and then when you look at the impedance, you can actually see that the line has already gone up and then up here. So this is already, the impedance is lost. So that is why this part of the AEEG cannot be interpreted. Okay, so that is in regards to impedance. So impedance is high, then you need to work on your electrodes. So that is why I say the needles are so much easier to use, because once we place it, generally it will stay there until we take it out. Okay, next we will talk about background activity. So background activity just means that how the baby's brain, the electrical activity is in the brain. So it is classified either with the simple voltage criteria or pattern recognition. So I think some people are more familiar with this simple, where they just divide it into normal, moderately abnormal, and severely abnormal. Whereas here, I train all my MOs and PACA to do the pattern recognition, which is also not difficult to do actually. So for the pattern recognition, we divide it into continuous, discontinuous, burst suppression, low voltage, and flatline. Okay, and basically, how do we divide all these things? Is we look at the lower margin and the upper margin of the AEEG activity band. So this is the AEEG activity band that will be displayed on the CFM. So when you look at the activity band, I always tell people to look at the place where it is the most dense. Okay, so if you can see here, actually the dense part is up here rather than all the less dense areas here. You get what I mean? So why is this important? Is that for example here, people will actually some people will actually interpret this as discontinuous, because they say the lower margin is below 5 and the upper margin is up here above 10. But when you look at the most dense area, you can actually see that the most dense area is actually here and here only. You get what I mean? So this actually, the upper margin is way down here and the lower margin is down here. Okay, so you look at the most dense band to see. So here you can see the lower margin is above 5, upper margin is above 10. So this is a continuous waveform. Okay, and then when you see a continuous waveform, this is essentially normal. And then another thing that if it's already a continuous waveform, another thing that we are looking for is actually a sleep-wake cycle. So you can see that the band actually widens and then it narrows and then widens and it narrows. So that is very good actually, because this denotes sleep-wake cycling, which is even better than if you just see a continuous waveform. Okay, so that is continuous. Next is discontinuous. So discontinuous, the lower margin is below 5. Okay, and the upper margin is above 10. So it looks like a very broad band of waveforms. Okay, so this is discontinuous. Okay, so next is burst suppression, where I say, so here onwards, burst suppression, low voltage and flat trace, both the lower margin is below 5 and the upper margin is below 10. Okay, but then when you look at this waveform, you can see like these lines coming up from the dense waveform, and this is a burst suppression pattern. Okay, and then low voltage, the lower margin is below 5, the upper margin is below 10, but you don't see all these lines that is going up. And last but not least is the flat trace, where there's nothing in there. It's just a flat line only. Okay, so the severity goes from here, which is normal, to less normal and moderate, and also very severe abnormal waveform. Okay, so the background activity is just that, and we will describe it according to the pattern recognition. The pattern, the background activity actually varies with arousal. So that is when you see the sleep-wake cycling, medications, and gestational age. So sometimes if you give the baby sedatives like midazolam infusion, morphine infusion, or phenobarbital, the background activity can actually become subdued. So so generally we would like to take all those things off, and it will give a better idea on whether the background activity is actually good or not. Gestational age, so a term waveform differs from a baby with a preterm waveform, in the sense that the more preterm it is, actually the lower margin kind of drifts downwards. So, but we don't use the AEG quite frequently on the preterm baby. So it's generally we should know how to interpret in a term baby. Okay, and it evolves and fluctuates over time. For example, if you put a baby with neonatal encephalopathy on AEG, what you want to see that is that the CFM actually improves from one background activity to the other. Okay, and then preterm baby, it looks kind of similar with a discontinuous background like I mentioned just now. And then by 36 weeks, it should look like a term baby. Okay, and last but not least is the sleep-wake cycling that we will look for if the waveform is a continuous waveform. Okay, so those first is the impedance, second is the background activity. Now we go for the third part, which is the seizures. So on the EEG, okay, the raw EEG, seizures are suspected when there is a sudden, repetitive, evolving pattern. Okay, so number one, it must be sudden. Number two, it must be repetitive. Okay, and with a clear beginning, middle, and end. So minimum duration should be 10 seconds of the electrical activity. So sometimes we see it very, very brief patterns. And sometimes if we see those brief patterns, we kind of ignore them. And on the AEEG, there will be abrupt rise in minimum and maximum amplitude. I'll show you later, or what we call a capping, okay, capping of the waveform. And then once we see that, we will need to review the raw EEG, because artifacts also can present like that. Okay, and seizures can be classified as single, repetitive, or status epilepticus. So on the AEEG, when do we suspect that the baby might be having seizures? Is when you see like this, the background activity is nice like that, consistent, and suddenly you see a capping, meaning that the minimum and the maximum actually goes up and then it comes down. Okay, and then it continues on with the background activity. So we would like to put our cursor here, and we want to scroll from the beginning until the end to see what is happening here. So you can see this is very repetitive, right? Okay, so that is very, very classical of a seizure activity. So it can come in various forms. So you can see this is a discontinuous background activity, and suddenly there's a capping here. Continue on with the discontinuous background, and then another capping here, and another capping here. So you want to put your cursor here, and then you scroll, and then you can see that this is repetitive. Then you can also see very, very, very frequent capping. Okay, and this is all seizure activity here actually. Okay, this is less frequent seizure activity, but it's also still very frequent. Okay, and then here you can see the same things here. And this is probably a status already. That means the seizure activity is beginning from here until here. And you can see, look, if you look at the time, that is like what, this is midnight. So maybe maybe 12:30 midnight until about 3 o'clock. And this is missed, okay? No one came to see the AEEG. Okay, so once you have looked for seizure activity, last but not least, we look and see whether that abnormality we see in the AEEG, can it be an artifact or not? So the commonest artifact is the electrode placement, which I've already shown you what it looks like. Just means that the impedance has gone up. The electrodes means that the electrodes have already out from the skin, so you need to reapply that. Sometimes, like I mentioned, the electrodes can be touching each other, okay, or what we call connected electrodes, and the tracing will be very abnormal. Okay, next commonest artifact is when the baby is being moved. So for example, suctioning or baby care is being done, and then that will also sometimes look like a capping or seizure has occurred. So that's why you need to look at your raw EEG, and if you have video EEG, you can also have a look at the same time. And HFOV and ECG, because of the amplitude of the HFOV and the ECG waveform, it actually causes a drift of baseline upwards. So here, what do you think happened here? Suddenly become very, very high. Okay, and then when you put your tracing here, it's all over the place. So this is most probably a disconnected electrode. Okay, here you can see a capping, right? So if you don't look at the EEG, you say, oh, this is a seizure, and then give phenobarb. No lah. But if you put cursor here, there is no repetitive waveform that you see. So probably the baby is being moved or something. Okay, that's why you have that capping. But if the baby is being moved, actually you see a more haywire kind of a waveform. So this one you can see rotatory like this, right? So what do you think it is? Okay, this is a transmitted waveform from the HFOV. And when you see that, you can see actually there's a drift in the baseline upwards. Okay, go up like that. Okay, and that is just an artifact from the HFOV. Okay, and then here you don't see a capping, but then when you see closely, there's a drift of a baseline from here to up here. And this is actually ECG, transmitted waves from the ECG. So how do you know this is from ECG or not? Number one, it will look like an ECG waveform lah. Number two, you can actually, if this is happening in front of you, you can actually look at your cardiac monitor, and it will actually correspond to your heartbeat lah. The baby's heartbeat, I mean. Okay, so you can know that this is just an artifact. So generally, so that is how we interpret the AEG lah. Okay, so it sounds quite simple, right? But sometimes it can be not so simple lah, because you're not sure what we are looking at. Okay, so when do we use the AEG? Generally, we use in the term babies, in the monitoring of our baby with neonatal encephalopathy. And people have used that for treatment, especially with their seizure activity, and also to start cooling therapy, for monitoring, and also for prognosis, whether these babies are going to be okay or will be very severely abnormal in the future. And at one time, it's also an inclusion criteria for therapeutic hypothermia, especially in the landmark studies when we started using therapeutic hypothermia. Okay, so that is the first group of babies. Secondly, if we think that the baby might be having seizures, we can actually put the AEG on, and then we monitor from there. And meningitis and congenital heart disease are actually less likely for us to use it. For the preterm baby, generally we don't use these, probably in a research setting or in other places, for the monitoring of preterm baby with brain injury or intraventricular hemorrhage. So for just a note on the usage of AEG in neonates with neonatal encephalopathy or HIE. So as I mentioned, it was a criteria for the TOBI trial and the CoolCap trial. It is used as one of the criteria as an inclusion criteria to start the cooling therapy. So it is just an adjunct, but not the sole criteria. AEG also can be used for prognostication. So if we see a normal AEG at 3 to 6 hours of life, it is actually associated with survival without severe disability at 18 months. But the converse is not true, meaning if you see an abnormal AEG at 3 to 6 hours of life, does not equal to survival with severe disability. Okay, so that is not, the converse is not true lah. But if we see at 48 hours a normalization of background activity, means that for example from burst suppression and then all the way up to continuous waveform with sleep-wake cycling, then that is associated with good outcome. But if we see an abnormal background at 36 to 48 hours, it's associated with poor outcome. If we see sleep-wake cycling, like what I mentioned just now, it's associated with good outcome. And then the presence of seizures can be associated with poor outcome, but it's non-conclusive. Okay, so I've seen babies with not very frequent seizures, maybe once or twice, and then very easily controlled. Those are also do well after that. But if you see very frequent seizures in the beginning, that is generally the babies will have poor neurology status after that. Okay. So what are the pitfalls of using AEG in neonatal seizures? Number one, a normal AEG does not rule out seizures, because you remember we only use C3, P3, C4, P4, or F3, P3, F4, P4. So sometimes if the foci of that is causing the seizure activity is not near these areas, it will not pick up the seizure activity. So continuous EEG is still a gold standard in the analysis of a baby with seizures. Although that being said, it is also 76% accurate to detect seizures in AEG compared to conventional EEG. Why is it less accurate? It is because it does not detect seizures which are short, number 2 which are focal, and number 3 which are low amplitude. Because like I mentioned just now, when the raw EEG is changed to AEEG, the ones which are below the 5 hertz are actually filtered out. Okay, so the low amplitude seizures will not be picked up. Okay, and last but not least, there can be artifacts that can cause these abnormal findings. Okay, so that's basically it. I think we got, how long do we have left?
Dr. Eric, we have 5 more minutes.
Yeah, so I'm essentially done. This last part is actually a practice to those who want to practice how to read an AEEG. But just before I go to that, I just want to summarize a bit. So generally, I think people are still afraid to use it and they find it very difficult. So you need to keep in mind that AEEG is, at the end of the day, is still just a monitoring tool. It is supposed to be used in conjunction with your clinical findings and also the raw EEG. Okay, so so we need to remind ourselves that it is just supposed to help us to come to a diagnosis and also a monitoring. So it's a lot of times not diagnostic in itself. I think I hope that is understandable. Okay, and then when you need to know your machine, you need to know how to place your electrodes, and then what are the difficulties that you what peculiarities your machine has compared to other machines, basically. And then last but not least, when you interpret and how you document it, number 1, you talk about background activity. Number 2, whether there's seizure activity or not. And that's generally how I document my CFM findings. So I would put that as, for example, discontinuous waveform with no seizure activity. That's my CFM. But when I read it, the first thing I will look at is the impedance. And to make sure whatever abnormality, I will need to go to the raw EEG before to make sure that it's not the artifact. Okay, so this is not very nice. But anyone want to try? This is number 5, number 10, 15. Since no one want to try, maybe we ask the moderator to try then. Actually, anyone listening to me or not?
Is it this continuous pattern, Dr. Eric?
Why do you say this? Okay, first of all, what are you supposed to see? You just go through the steps. Number 1,
the impedance.
Yeah, so this is impedance. This is 10. So this is a good impedance, right?
Yes.
Okay, secondly, we look at the background activity. Where is the lower limit? Is it above 5 or below 5?
It's
This is 5.
5 is below, above 5, sorry, it is above 5.
Okay, above 5. And
Yes.
is the upper limit above 10? This is 10.
It's above 10.
Okay, so both are above 5 and above 10, right? So what should it be?
It's a continuous then.
Correct. So it's a continuous background activity. Okay, so 2 other things that you're supposed to comment. Okay, whether there is a sleep-wake cycling. Do you think there's a sleep-wake cycling?
There's no sleep-wake.
Maybe just a little bit. You can see this sort of like broadens here and it comes down, right? And lastly, whether there's any seizure activity or not, right? So we don't really see a capping. So that's it's so I don't think there's any seizure activity here, okay?
So
sorry.
We just comment on these 3 components as Dr. Eric said, just like impedance, and then see the because this is quite new to us because we just recently had the AEEG. So
Correct.
that is the systematic approach, then we can
That-
say that.
Correct. So that
Oh.
is how I do it. I'm not sure
Oh.
whether that's how other people do it or not.
Okay.
But when I document in the case notes, I don't document the impedance lah, because it is, if the impedance is not correct, then I won't even comment on the waveform as well.
Okay.
Okay. So but when I document in the case notes, I will say, let's, for example, here I will say there is continuous background with sleep wake cycling and no seizure activity. So that's how I document the CFM finding during rounds lah.
Okay. Thank you, Doctor.
Okay. How about this one?
It is continuous
Okay.
because it's above 5 and the upper margin is above 10.
Yeah. And so here there's no impedance lah. So that's why you have to look at your impedance first lah before you comment on these things. Mhm.
And then,
So this is a continuous background activity.
I think there is sleep wake cycle.
Okay, very good. So this is sleep wake cycling. And then,
Seizure, we don't think
yeah.
seizure activity as well.
Okay, so there's no capping, so there's no seizure activity lah. Okay. Okay, this one. So assuming that the impedance is good. lah.
This is a discontinuous because the lower margin is less than below 5 and then the upper margin is above 10.
Correct. So and no seizure activity, right?
Yes, no seizure activity.
Okay. So it's all the same person answering, is it?
But I'm trying with all my colleagues actually. We are
Oh, so they are encouraging you on.
yes, yes.
Okay. So maybe I just do two more. So can we comment about let's say this one? This one. Assuming that the impedance is good. This is two different waveforms. So assuming your impedance is good.
This is
So where's the lower margin? This is the lower margin, right?
below 5.
Okay. And then how about the upper margin?
It's above 10. So it's discontinuous.
So like I said, you want the band that is most dense, right? So you can see that this is actually the band that is most dense. It's actually just at 10 and below.
Okay.
So this is actually burst suppression. So yeah, so this is also burst suppression. This is also burst suppression.
Oh, okay.
Okay.
Yes.
This is more severe one. And the last one, okay, this is artifact, what it looks like. So if you put your cursor, where's my cursor? I think this, can't remember which is the cursor. So generally you see the raw EEG going up and down like that. Then you know this is an artifact. The baby is being moved. Movement artifact, sorry. Okay. This one. Who wants to try? The last one. Assuming that the impedance is good also.
I can try, doctor.
Yeah, sure.
This is severely abnormal.
Would you like to describe the background?
The lower margin is less than 5.
Okay.
And the upper margin is less than 10.
Okay. Where is the upper margin? Do you think the upper margin is here or this one?
I think the upper margin should be the pointer you are showing.
Yeah.
Around.
Yeah, that's correct. Okay. And then, so what background activity is this?
This one is low wattage.
No, this is burst suppression. So because you can see all these lines coming up from there, right?
Yeah.
Okay, so I'll just show you in a while what low voltage looks like. And then what else? Other than, so this is burst suppression, and then?
No seizure activities in.
Why not? You can see this is capping, this is capping, this is capping, this is capping, right? Correct?
Yeah.
Okay, so when you put this red cursor here, right at the middle, this is the raw EEG, which is down here. You can see this is all very repetitive, correct?
Yeah.
So this is actually a seizure activity. So this is burst suppression with seizure activity. So what I would do if I see this, I will put my cursor from here to here. I'll put my cursor here, then I will scroll and see and look for this repetitive one. Then I will go to the next one, and then the next one, and the next one. Okay?
Okay.
Okay, so let me just sorry, just go back to my, where is it? Okay. So you can see low voltage, there's not much of this lines above it, which you see more in burst suppression, right? This is not much. Okay. So this is the sort of a difference between the burst suppression and the low voltage. I think that's it. Hopefully, yeah, I think I'm done. I hope that that is a little bit more clear some of your doubts about using AEEG. Okay, any questions?
Sorry, I think Dr. Eric, have posted a question on the chat box for you.
Oh, I can't see the chat box because I'm maybe I'll go.
Okay, I will read the question to you.
Yeah, sure.
Okay, wait there, Dr. Dr. Eric, what is the distance between the C3 and the P3 electrode?
Okay, so the distance C3 and P3, I will need to go back to this. So different size of the because different people have different head, right? So some people have smaller head, some people bigger head. That is why they use the international 1020 system. So if you are looking at C3 and P3 here, C3 and P3, C4 and P4, correct? Okay, so what you're actually supposed to do is we measure from these triggers to the other triggers. Let's say that is 10 cm, correct? So we will need to measure 10 of 10 cm, which is 1 cm here to get your T3, and then another 20 cm, which is so 3 cm from the triggers. Okay, so that will correspond to your C3. Does that make sense? Okay, and then we will also need to measure from the nasal bridge right to the occiput, and to get a number, and then you work your way towards getting P3. You need to measure all this first, following this percentage. Then only you go. To your P3. So the the technicians need to be very precise when they put the electrodes. So that's why for us it's like very difficult. And most of the time I just agak put at this, around this spot and this spot. And usually I will still get a good tracing. But that is why it is beneficial to use this ruler. Okay, because if you use this ruler on a term baby, the ones that I passed to you all, the arrow here, you can see this arrow. There is two arrows now pointing up and also down. When you use this already correspond to C3 and P4. C3 and P3. Okay, so that is how you put the electrodes. Does that make sense? Am I still connected?
Yes, Doctor. Thank you, Dr. Eric, for your explanation. I think there's another question for you.
Okay.
Dr. Eric, is there any explanation for why we use the 5 to 10 microvolt specifically for the background interpretation?
Oh, that one I don't know. we will need to ask Prior and Maynard to choose that. So we all, basically the AEG is supposed to make our life easy so that is why we are not experts in reading EEG. Okay, so it has been made so simple that even people like us like me lah, okay, in the NICU, it's readily accessible and gives a lot of sort of information to help me make day-to-day clinical judgment lah. So that's what we need to remind ourselves with.
Okay. Thank you so much, Eric.
Okay.
I think that's all for this one. Really,
Derek, can
Yeah.
I ask a question?
Sure.
Derek, I was wondering, we know that Hospital Kulim is only started using, just a minute, Derek.
Sorry, there's a lot of echo.
Yeah.
Kulim is still just started using. Okay. Hello.
Derek, hi.
Yeah.
Dr. Vijay here. Just want to ask, Hospital Kulim has just started using the EEG machine, right?
Okay.
And then in your setting, because from what you presented, it was a very good presentation regarding how to apply the electrodes and how to monitor and everything. So in your
Okay.
setting, who is responsible for putting on the electrodes?
My medical officers.
Medical officers. Okay.
So this is a CFM, so it's not, I understand in some places they get the MA to do it, or the nurses are the ones doing it, right? So for us, it has been traditionally the MOs are doing it because we were using needles before. And then the MA, we don't have a specific MA who is actually familiar with this device. Only now that we have Dr. Tan Ken An with us, that we have sort of PITS Neuro MA, which deals with the EEG machine and not the CFM. So our MOs are still doing it.
Thank you, Dr. Eric. At least it gives an idea of in our setting while we...
Sure. So if ever I visit your unit, I think I should have a look at what your device is and see how I can help you all with that. Okay, any other questions?
I don't see any more question in the chat box. I think that's all for your session, Dr. Eric. Thank you so much.
Okay, thank you.
Very much. Yes, Dr. Eric. Thank you so much for your talk. So
Okay.
now we are... Okay, thank you. Okay, so now we are moving on to our next topic of the day by Dr. Moise.